Hi, good afternoon, everyone. Namaste. So my name is Bernie Chang, and I'm the president of the Royal College of Ophthalmologists in the UK. Thank you very much indeed for the invitation to the college to run a 1.5 hour session for you. And the title of this session is called Innovations in Education and Training. We certainly wish everybody here and their family well. It's very good to hear that the COVID infection rates have dropped in India. Now obviously, we are fully aware that the ophthalmology services in India is many times larger than we are in the UK. So in a sense, we are quite a small service compared to what you run over there. And no doubt the challenges that you face, especially due to COVID, will be bigger. And we are hopeful that we're able to give some useful tips, especially on how you can continue training and educating ophthalmologists over there. So an introduction to the speakers. So I'm a consultant oculoplastic surgeon based in Leeds, which is up in the northeast in England. And I specialize in managing periocular skin cancer, thyroid eye disease, and have an interest in artificial eyes or prosthetics. And as you can see, I have done a fair amount of work for the college, but also for other external bodies. We also have Ms. Fiona Spencer, who is our chair of training at the college. And she's a consultant in Manchester Royal Eye Hospital, specializing in glaucoma, cataract, and she has a particular interest in the training and curriculum and medical leadership. She has also had various other roles, including as Associate Medical Director at her local hospital. Melanie Corbett just finished her term as our Chair of Education and Tele, and she's a consultant ophthalmologist in London in the Western Eye Hospital Imperial College. And she has a special interest in cornea ocular surface and anterior segment surgery, and is really, I think, a world expert on education. Our final speaker is Mr. John Ferris, who leads our surgical skills faculty at the college. And he has a special interest in surgical training, simulation, and pediatrics and squints. So in terms of the timetable today, I'm going to give a very quick overview about the impact of COVID on services in the UK and training. And this will be followed by a presentation on remote assessments and exams by Fiona Spencer, cascading training to trainers by Melanie Corbett, and remote supervision of simulated training by John Ferris. And we will have a discussion panel at the end. So please do ask any questions, which we will collect in the Q&A box. So without further ado, I'm going to start and talk about the impact of COVID on training. And the main effect it had initially was on how we provided eye care services. And obviously that has an impact on the ability we have in the UK to train. I'm going to talk about what the impact on our trainees here and what the college did in order to try to help restore services and training, and how these ideas can be taken even post-COVID. And the three presentations following mine are talking about specific innovations for training and education. So in terms of capacity, in terms of the ophthalmology workforce in the UK, you can see that we do a lot of work. We account for 10% of all outpatients in the NHS, the National Health Service, and we do 6% of all the surgeries. And this is done really by quite a small group of medically trained staff. There's only about 1,260 consultants in the UK. And therefore, we have really learned to work as part of a multidisciplinary team, working particularly with optometrists, but also with orthoptists, nurses, and technicians. So in a sense, we punch well above our weight in terms of the workforce and what we deliver. We know that from the Way Forward document that we produced, that in the next 20 years, we expect that there will be a 50% increase in demand for cataract surgery, a 44% increase in glaucoma cases, and 60% increase in the overall caseload for diabetic retinopathy and AMD. And the population is living longer. And we know that as we get older, we tend to get more than one disease. So multiple comorbidities will exist. So the complexity of the patients that we treat is also going to increase as the aging population increases. A problem that's not unique to the UK, but I'm sure is also prevalent in developing countries, is that there will be a more rapid rise in the older population in rural areas versus urban ones. This is because young people tend to move from smaller areas into big cities for jobs. And likewise, those who are retiring in the cities are more likely to move out to the rural areas for retirement. So that again increases the complexity of work in those areas. All this was before COVID hit. And when COVID hit, all routine eye care services were shut. And there was really this risk that thousands of eye patients were going to suffer from avoidable sight loss because they just were not attending even when they had urgent eye signs. They were afraid that they might catch COVID if they come into hospital, where obviously all the COVID patients were being treated. So in terms of the backlog, in 2021, we expect that there are now 5 million patients on the waiting list. This is for all of NHS, all of services, and that 4 million patients haven't even been referred yet for surgery that they probably will need. So the backlog is immense. As a college, when COVID first hit in March of last year, we set up a COVID-19 response team, and we made sure that we worked closely with NHS organizations and government representatives. We made sure that we wrote service guidance with initial focus on how to look after patients with emergency and sight-threatening conditions. So advice on how we prioritize care. And we wrote guidance on how PPE, personal protective equipment, should be worn, and how to create safe environment in clinics, from something as simple as the breast shield that we used to have for slit lamps. And then we started to write guidance on restoration of services and training and research. We really had to rethink delivery in order to reduce the need for patients to come into hospital, both because the hospitals were very busy looking after COVID patients, but also to reduce the risk of a patient coming to hospital where COVID was much more rampant. So we started to use telephone and video technology to conduct remote consultations. And we continued to prioritize in terms of risk for patients as to who needed to be seen face-to-face or who could be managed remotely. Following the first wave, we knew that we had to try to retain capacity as much as possible because the backlog was just increasing. And effective communication and early communication with your trust managers and patients was crucial. So we still continue to ensure that we prioritize and that we try to provide safe elective care sites. For example, standalone eye units were more able to continue with surgery rather than in a hospital where the eye department was part of a busy A&E or part of a busy ICU department. We definitely needed the support of our optometry colleagues who worked in the community to try to see more patients there. And we set up ways of sending data, so OCT pictures from the optometrist into hospital via something we call CUES, which is the COVID Urgent Eye Care Service Pathway. And we also started to work with local charities and eye clinic liaison officers to ensure vulnerable patients were not missed. And this really helped to reduce the do not attend, patients failing to attend our clinics. Within the hospital, we also risk assess vulnerable groups of staff For example, the ethnic minority community suffered more from COVID in hospitals, and some staff also had to shield in order to protect themselves. So beyond the first wave, we continue to develop and adopt safe and efficient pathways for working. We're definitely increasing collaboration with our MDT staff. We're setting up high volume cataract surgery and high volume diagnostic hubs out in the community so that patients can be assessed there and then remotely managed by a consultant or senior doctor in the hospital. Now, there is hope for normality in that the vaccination program has worked particularly well in the UK. Something new for our college is that we started to work more closely with the pharmaceutical industry to get sponsorship for education packages, but also for setting up community hubs. So this is just a list which you will all be provided for of the COVID guidance that we've written, and you can look at these at your leisure. In terms of our trainees, we have a 7-year ophthalmology training program, and it's usually through national recruitment that they get in, but there's also the route through what we call CSER equivalents. So those who are not in training, not consultants, might work in what we call a staff and associate specialist grade, and there is an opportunity as well for them to enter OST training, provided there are gaps in the rotation. And obviously there are different types of visas that the UK provide for overseas doctors to be able to work in the UK. And the college runs a dual sponsorship scheme for that. In terms of the staff and associate specialist grade, you can actually get equivalents to become a consultant, to be on the specialist register. This is what we call CSER. And very recently, the college was involved in creating a specialty grade. So this isn't quite a consultant grade, but it allowed for autonomous work by senior SAS doctors with the appropriate experience and qualifications. And that obviously comes with better pay. The impact of COVID on training was huge. Our trainees were redeployed because the eye department was virtually just doing emergency services. Our trainees were used to help cover wards, and some also worked in the ICU units. And quite a lot of trainees, as you can see from the initial survey that was done in May 2020, were concerned about the impact on training. And not surprisingly, the area where they were most concerned about was in the ability to learn how to do cataract surgery. And the more junior you were, the more you were worried that your chances of learning this vital skill was being delayed. In August of 2020, this picture was still very similar in that 72% of trainees felt that they were not going to be able to complete their training objectives, and 47% of them had one of their exams cancelled. In the most recent publication, and Fiona Spencer might also talk a little bit on this, our trainees still feel that they have been disadvantaged by COVID. And so quite a lot of them feel that it will impact on their future career and their ability to sit the exams so that they can progress within their training. So who's most affected? It's not surprising that the earlier trainees were more impacted. Those trainees who were less than full-time, those trainees who were shielding, and academic trainees were particularly hit. And trainees who had caring responsibilities also suffered particularly because of COVID. So what can we do? I think as trainers, we have to rethink how we supervise. We have to make most use of the opportunities we have and to utilize new ways to teach trainees, which the subsequent presentations will give you a bit more detail about. But we know that clinics are less busy. And so therefore there is an opportunity to use that time to allow your trainee to be more supervised, to give them more feedback, and to give them time to take histories from patients and for you to observe them more carefully. Likewise, in theatre, because lists were not running at full capacity, you might have the opportunity then to actually allow them to do the case because you're less stressed for time. In terms of training for future eye surgeons, we know that the NHS was very busy looking after COVID patients. So we started to work with our education bodies to see whether the independent sector, the private sector, could also offer training opportunities. And there we were very careful to make sure that the standards of training delivered by the private hospitals were at least equal, if not better, than those that they would traditionally get. So that's just a very quick overview about what happened due to COVID, the impact on service and training. And no doubt it has been very challenging and remains so, and that the balance of providing the service and training will be tested in the months to come. But we do have to be creative and use all opportunities to train and to use any appropriate setting in order to deliver training so our trainees can become good consultants eventually. So I'm now going to pass over to Fiona Spencer for the next bit.
So thank you very much, Bernie. Good afternoon, everybody. It's lovely to be here with you. And I'm going to expand a little bit on what we have been able to do in remote assessment and examinations to respond to the changes that COVID has thrust upon us. So as you can see, we have to live and train with COVID now long term. And Bernie has told us how we have to think very much about how we make our assessments particularly meaningful. And certainly many of our trainees now have to undertake far more remote assessments than they ever had to. So we have to think about the important qualities of good supervision, and that it must be both normative, so it ensures that the trainee can provide high quality care, and it must be formative. So the supervision itself must be good. We must actually give them feedback on all aspects that they're undertaking. And it must be timely, and it must be very specific so that it's excellent and also helps provide this high quality care. But it also must be restorative. So it should be something that enhances the well-being and the development of the trainee overall so they can maximize their potential. So I think it's been quite a change for all of us to have to undertake more remote consultations. And I'm going to mention video consultations using Attend Anywhere specifically. But I'm also going to say that many of our trainees had to undertake telephone consultations. Now, as a glaucoma specialist myself, undertaking a glaucoma consultation by phone is not going to give me a lot of answers as to whether a patient has changed or we have worries. But it did allow us to check in with patients as to whether they'd become symptomatic or whether they were taking their drops and getting repeat prescriptions, particularly if they were shielding and struggling at home. It also allowed us to phone patients directly if we'd undertaken a virtual review, perhaps of measurements that had been done, and to then look at writing to them and giving them information personally. So certainly the Academy of Medical Royal Colleges in the UK recommended that we should write to patients directly. And after our virtual review clinics, we do that much better. So again, for trainees, this is about checking that they're able to write a letter that is in a language that's comprehensible to our patients and makes sense to them and makes them feel empowered in their care. So I think at the beginning of this, we were all thrown into a strange situation, and perhaps we didn't think too well about how we might train people in remote consultations. But it is really important because, of course, we all know that watching a Zoom meeting rather than being in a live meeting can be quite tiring and difficult. Why is that? Well, it's because we have less clues from body language than we do if we're sitting or talking to people. And so parts of our brain that we're not using otherwise have to be switched on differently for us to be alert to these changes and to think about how we might find out how somebody is feeling. So I think that's why we're all more tired after we've been on a Zoom meeting. And if we're going to have video consultations with our patients, we have to be alert to those subtle clues. But it's also a really good time for refining your relevant history taking and getting trainees to really focus in on what's important. So maybe at the beginning, considering a script or pro forma and getting them to develop it. And then using a proper framework to give feedback on how the trainee structures their consultation. Do they cover the patient's understanding, their concerns, the expectations of this consultation? Is there a good closure effectively as well? And then giving feedback to them on all of that, including their written letters afterwards. And this can be done very well for our shielding trainees, as Bernie mentioned. So for example, our oculoplastics and primary care team found Attend Anywhere particularly useful. Both the trainee and supervisor have a link to meet with the patient. The patient comes in from a waiting room, and then they're able to share their scans, pictures, or whatever as required. What can happen then is after the trainee has perhaps taken the history, they can ask the patient to wait again for a moment, and the trainee and supervisor can discuss what needs to be done. And then the patient's invited back in again from the waiting room, and the trainee can give the feedback and then present to the patient what needs to be done. And again, at the end, the supervisor can give further feedback to the trainee. So that's not that different, particularly, perhaps from what we do in clinic. And one of our consultants who was shielding for a while was able to do this with their trainees regularly. So I've alluded that giving feedback on virtual assessments is important. And again, there's quite a lot of things you can make an assessment of with that trainee, and you can do it via Zoom. So understanding and interpreting results, the decision making for patients, the follow-up and future planning for their care, as well as their communication. You can also think about all those other generic professional capabilities that the trainee should be able to demonstrate and needs to continue to develop despite COVID. So for example, remote review of presentations or a teaching session that's done online. If you have good structured feedback, thinking about the different steps of what they've done and how well they've done that will also be very important and useful. And that could be true about a research project in the same way, or a leadership project. So in your educational supervisor role, instead of being on Zoom as here with lots of people, you're going to be in a one-to-one relationship with trainees. And at first, I think we worried that this may seem a little strange for them, but actually they're often in their home environment when you're doing this, so they can be more relaxed and able to discuss freely with you. So as long as you make regular contact and update at mutually agreed times, it can work very well. And for some of our trainees who were shielding, this was weekly, at least with their supervisors. And it's important to think about their well-being. Certainly, I think the focus in the UK for NHS staff members on well-being has really changed recently, which is very helpful. You can talk about those generic capabilities so that they're still getting on with other projects, their research projects, if they are not in a laboratory, their audit projects or quality improvement. You can also encourage them to be planning ahead and talking to their clinical supervisors about how they're going to take advantage of those opportunities. And it's a good time to start thinking about what the long-term career plans and aims are, and what evidence they're collecting long-term in their e-portfolio. So of course, this year we had to do our national recruitment remotely, and we normally have 90 consultants undertake recruitment in a large hotel actually in the southwest of England, with approximately 250 candidates who are seen on 14 tracks of going around 3 sets of stations. So we were very concerned that if we were going to simply be doing this by assessing their portfolio, that we kept some of the things we thought were very important. So our trainees undergo a machine marked test, which is a multi-specialty recruitment assessment on problem solving and managing professional dilemmas. And this is used also by GPs, by psychiatry, and other specialties. And so we remove perhaps the lowest scoring applicants from that only. And on this occasion, this year, as we had 255 slots, we had a record number of people applying for ophthalmology with over 600. So we shortlisted down to 255 slots on their portfolio, which they submitted completely scanned remotely and was assessed by 2 assessors. But we thought it was really important that we could check they had good communication skills, as it's part of our normal recruitment process. So we had an online patient consultation by Attend Anywhere that was marked by 2 assessors remotely, and this went extremely well. So now I'm going to show you some slides that have been prepared for me by our exams team, because we had to make massive changes as well to our examinations. So our current exams are that we have an undergraduate prize exam, the Duke Elder, and we have then the FRC Oph Part 1, the refraction certificate, and then the Part 2 is taken as 2 halves, a written and then an oral exam. And we also have a certificate for laser refractive surgery. And of course, we were stuck in lockdown. We had examination venues restricted, the hospital that was going to hold the exam, or in many situations, the options were closed. We had examiners who couldn't also attend or travel. We had candidates who were going to have problems with that. We thought that using masks could possibly lead to communication problems, and that face-to-face, we would be putting the patients we'd examine at an additional risk unnecessarily. And of course, then false social distancing would make it difficult to set up, and real patients we'd be therefore unable to use. So we had to put in new mechanisms in place to develop exams to run well during COVID. And this is an example in the refraction stations. So for the Part 1 and Part 2 written exams, we already have these undertaken in the driving test centres where patients go for their recruitment SRA tests. In fact, these were closed but open again for our recruitment, luckily, but not open enough for us to do our exams. So we moved to online proctored delivery, where candidates take the exam at home and are watched by a live proctor through their webcam. And we have a ratio of 1 live proctor to 6 candidates. So it's available to anywhere in the world without having to come to the UK. And it's been run 3 times successfully. And we've also run the Part 2 exam with great success too, having an exponential increase actually in our global candidate numbers because of this online delivery. Again, for our refraction certificate, we could not use real patients. So we used retinoscopy OSCE simulators, and therefore the exam became more retinoscopy based than full refraction. But the GMC, our General Medical Council, approved these changes, which had to be submitted to them. And we've implemented this as well. We have iPad-based electronic answering and marking, so there's now no subjectivity in that. And with our strict protocols in place, we were able to run this with the candidates attending live, but to undertake the retinoscopy stations. And it ran successfully twice, and we were able to put more candidates through, which helped with the backlog. And then for our Part 2 oral examination, again, as we couldn't use real patients, we went to modified OSCEs. So because we were concerned that candidates must show that they could examine the eye as well as pick up the signs from a video, they had to undertake those assessments, which are normal workplace-based assessments in our curriculum. They had to undertake them again with an examiner local to them to show that they could undertake them properly. And then on the day, they had clinical OSCEs with videos that had been filmed and edited at the host hospital where the patients had already been planned to come. So they came up socially distanced just to the hospital and had videos made of them. And this went very well with our electronic marking, and now has run 3 times and quite close together in 21 really, in order to cope with the backlog for our trainees. For the certificate for laser refractive surgery, as this is a specialist examination that's small, it had been on hold until the autumn of this year, where again it will be delivered online. And the viva is face-to-face without patients. So the future, of course, for us is that these post-COVID examination changes may mean that we change our exam structure somewhat overall. And we're hoping in presenting to the GMC changes that embed some of these as well in the future. And it will also allow us, with our new international host centres, to facilitate more global attainment of the exam. It's important to note, of course, that full FRC Opt is recognised by the GMC for UK registration, so PLAB exemption. So in the future for the refraction certificate, we would like to take the best of both, have our simulated retinoscopies, have a live retinoscopy and a subjective refraction. And we're awaiting the decision by the GMC on this, but it would be implemented in the middle of next year if possible, pandemic allowing. But having moved to this electronic answering and marking on iPads, we'll be keeping that. For the Part 2 oral exam, again, we want to continue with our simulated scenarios, but have some face-to-face volunteer patient examinations, so that will be considerably reduced numbers of patients required. And again, approval is needed by the GMC to implement this next year. And what about international exams? Well, we already currently go out to Malaysia, Singapore once a year and have a Part 2 oral there, as well as undertaking the refraction certificate. So our proposals in the future are that we may be hosting the exam sittings in India, Egypt, Trinidad and Tobago to begin in spring 22. And then the Part 2 oral, again to be in Trinidad and Tobago in spring 22 and in India and Egypt in October of that year. And we hope that in southern India, the following year in 2023, we'll be holding the exam again. And we're also looking at the introduction of a new qualification, the LRC Opt, that would be available globally. And this would be about recognising the successful completion of both of the written components of the FRC Opt Part 1 and 2. So this has to go to Privy Council in the UK before this can be confirmed. But then we hope that hosting that with the refraction certificate and the Part 2 oral outside of the UK, we'll be able to encourage more candidates to complete our full fellowship examination, as we know this is held in high regard now. And if you're interested in being an international examiner, you can have a great time doing this. We need more international FRC Opt examiners. Training and accreditation will be provided by us, and then it will be mandatory, of course, to do examinations with our examiners as well. And if you're interested, please contact our head of examinations, Dylan Costello, at dylan.costello@rcopt.ac.uk, and he will tell you more about that. So thank you very much. I will stop there. I'm happy to answer any other questions about training changes, and I will hand over now to Melanie Corbett.
Thank you very much, Fiona. I'm delighted to be with you today. Good afternoon, everyone. Can you see my screen share there? I'm going to be sharing with you the Training the Trainers programme, and particularly how we have cascaded the Training the Trainers programme throughout the UK and also overseas. And it's this cascade and able to deliver it in local areas. This has been particularly useful during the COVID period. I'll also be describing how we have used a remote delivery of education during the COVID period as well. So the aim of the Training the Trainers programme is to improve the delivery of training at all levels for all trainees. We know that the college has an important role in training because they set the curriculum right at the beginning, which then drives the learning objectives for the trainees and also the teaching provided by the trainers, and that hopefully results in learning. But the college is also important at the other end of training in setting the assessments, as you've just heard from Fiona. Hopefully assessment drives learning, but it also is a measure of how valuable that learning is. But there's this whole area in the middle between the curriculum and the assessments where training is delivered largely in the workplace and largely focused on patients. So it means that the trainers in every unit across the whole country needs to be training to the required standard in order to be able to provide this training. But as a Royal College, we've got to be able to oversee that and ensure that training is being delivered properly. So the benefits of good training is to shift the learning curve to the left. In the good old days, a trainee would pick up learning as they went along. But with a good Training the Trainers programme and well-trained trainers, you can enhance this by lots of preparation beforehand, making sure that the early phases of learning are very rapid. And then it means that the trainees can get much more involved in the clinical experience, learn more from that, and overall they can learn faster and reach a higher level. But all this requires a lot of input from our trainers, and our trainers need to use very good training skills in order to make the most of this time. So our training programme is competency-based. That means that our trainees need to develop skills at the top of this learning pyramid. The knowledge and comprehension they can obtain by self-directed learning through reading, through web, and this can be quite readily assessed in some of the knowledge-based exams. But in order to be a really good professional, they need to be able to apply this knowledge to know how to analyse what's going on, to make judgments, to make evaluations. So we end up with a workforce that's appropriately trained for their role, and that all the team members are working at their highest level of ability. And they've got to have really high level skills that are necessary for decision makers, both in the clinical setting, but they also need to have all the generic skills in training and management and leadership and research that go with that clinical role. And so the trainers need to be very well trained in how to deliver this upper portion of the learning pyramid. So just to give you an outline of the training structure we have in the UK, here is the trainee in their unit. They have a single educational supervisor who guides their personal and professional development. And then they have a whole series of clinical supervisors. And it's the clinical supervisors that oversee the safe clinical learning and experience in every session they do during the week. Each unit has a college tutor, and they're responsible for coordinating all the supervisors and trainees within their department and making sure that the training in the department runs well. Overseeing all this at the regional level is the training programme director. We have 24 regions in the UK, and it's the training programme directors that, that deliver the training, maintaining and assessing standards to make sure that everyone is doing their job properly in these units. And the training programme director works with the regional education advisor and the regional team to be able to deliver this education and training. So our Training the Trainers programme really provides training for all trainers at all levels of this structure. So the core courses that we run are these in green. The main course is the supervisor level course, which runs over 3 individual days, and it's repeated every year. And the course is pretty much the same with a bit of evolution each year. The college tutor induction day is very specifically to the role of the college tutor, but also introduces them to some of the necessary skills as well. And a slightly modified version of the supervisor course is delivered for trainees, because after all, our trainees are going to be the trainers of the future. So this is the core delivery of the Training the Trainers program. We also deliver TTT at advanced levels. So the advanced course for the TPDs and the regional advisors is different every time. And we're really trying to encourage these high-level trainers to be the best they can possibly be, and to all help develop each other. The regional leads and the regional teams each are responsible for a different area of education, and they have courses that are specifically designed to develop them in those different areas. And again, they're learning from each other, developing over time. In addition to this UK-based programme with the core and the advanced levels, we also deliver overseas training the trainers, and this is to Africa and also to Indonesia. So just thinking about the supervisor level courses, they are very much focused on how to deliver training. So it's what the trainer will be doing with their trainees in their units. It's got a theoretical basis, but we integrate that into it. We don't really teach the theoretical basis. We teach what the trainers need to be able to do. It's split into 3 days. So we have teaching and learning on day 1, supervision skills and assessment on day 2. And then day 3 is a slightly higher level on program management and also how to manage the trainee in difficulty. And this is just examples from the course that we've delivered in Africa. So you can see there's a very high emphasis on practical skills. They've done some preparatory work beforehand, before the course, but there's work in pairs, for example, setting aims and objectives. Here they are teaching practical skills using the 4-step technique. There's quite a bit of role play, for example, for giving feedback, for appraisals. But here, as well as the role play, we have an observer. So there's peer-to-peer feedback going on during the session. There's a role play here for trainee in difficulty, and a slightly larger group so they can all discuss how they can develop their skills. There's a lot of small group discussions about various topics. And one of the most important areas is at the end of every course, where delegates are planning how they're going to implement their newly found skills when they get back to their units. In the advanced level course, in the UK, these are single days. In Africa, we ran it as a 3-day course. And this is different every time. We choose specific topics of interest for discussion. There may be new topics or complex topics that just take things a stage further. For example, this particular advanced course in Africa, we were teaching how to cascade training the trainers' skills. So having been on the course several times, they were then actually delivering different aspects of the course. Either we split them into 4 different groups. So we had 4 people practicing presenting material to their delegates. They were facilitating, for example, supervising the practical skills. And here you can see they were also involved in large group teaching as well. But the key part of this was, yes, they were delivering the course that they'd heard before, but the real learning came from the peer-to-peer feedback and the amount of benefit they gave them that was huge. And we could see that by the way individuals developed over the 3-day period of the course. So how do we go about delivering the training the trainers faculty? So the important thing is that this is a sustainable process. So obviously we have a lead who runs a course. They've got a faculty who help them deliver the main materials, but we also have a group of facilitators who are helping the small groups to develop their skills during the small group practical sessions. And of course, on every course, we have all the delegates as well. But all the delegates who come on the course are not just learning about being trainers, they're also learning about being TTT faculty as well. So when we do the practical skills on the courses, we can select out those who are obviously best, and then they come on courses as facilitators. So they see the course again, but they get involved. Once they've facilitated a few times, they then become a faculty member, and some of them will eventually be a lead. So as well as delivering the course, we're developing the faculty at the same time. And this is on the national programme. But then it means that these faculty members, they come from all over the country, they're members of our regional teams, and they can then help deliver courses on a regional basis, and these are combined with our centrally developed courses. I mentioned regional teams there. These are regional educational teams, which are set up in all 24 regions of the country. They're coordinated by the regional educational advisor. There are various trainees and others who are there because of the role they hold at the college. We include the training leads, such as the training program director. But within every region, we have somebody who's responsible for all the different areas of education. So it means that every region has got a TTT lead. And within the regional team, the TTT lead might have support from, for example, the postgrad lead or the people responsible for teaching leadership or research. They may be actually feeding into the people who are providing simulation or the exams leads, for example, and mentoring and budgeting is very important to part of TTT as well. So this team all work together to help each other to deliver education and training within every region of the country. And it's this kind of cascade model which has been really useful during COVID, because as well as being able to deliver courses nationally, remotely, it means they can still get that facilitated development of skills locally. So we have the college leads here who provide courses for the regionally based TTT leads, and then the regional TTT leads can cascade this to their individual units. But the important thing is that these regional leads can all work together to give peer support and to develop their learning. We obviously started off with the ophthalmology specialty training program, which Fiona was talking about, but then we've realized over the last number of years that it's really important that we build this team into a multi-professional team. So we've developed over about the last 5 years the Ophthalmic Practitioner training program. This is based on and reflects the OST training program, and part of that has been to develop a whole TTT group, a parallel TTT program for trainers of the practitioners. So usually for the OST TTT, it's the ophthalmologists who are involved. These ophthalmologists are also involved in the practitioner TTT, but also we involve the orthoptists, the optometrists and the ophthalmic nurses, who are not only the learners on the course, but the senior members are also part of the Training the Trainers program. So we've also been cascading our Training the Trainers program in Africa. We've had a program running for over 8 years now with COEXA, which is the College of Ophthalmology of Eastern, Central and Southern Africa. And we have a strong link between our two colleges, and this is supported by the London School of Hygiene and Tropical Medicine. And this was a meeting at one of the inaugural sessions we had to get the whole link between the two colleges off the ground. So Training the Trainers has basically been cascaded with COEXA and the college together over 10 countries within Africa. It was part of the Vision 2020 program, and therefore we had 2020 as our final endpoint. And so it's split into pairs of years. In the first phase, we needed to create the ethos of training. In the second phase, we were developing skills in trainers. In the third phase, embedding training processes into the training programs. And then in the fourth phase, it was how training and the TTT program could be cascaded sustainably into the future. So in phase one, we needed to create the right ethos. And it really did show that in different parts of the world, we come from very different cultures. And what we want to try and do is to share the best bits of those different cultures as to how they promote training. And this collaboration was very much a two-way learning process. So as well as going out to Africa to help them develop their trainers and training programs, we brought an awful lot back home to it with us. And our Training the Trainers program has really benefited from this link. So in terms of creating an ethos, it's things, for example, that training skills can actually be learnt. So it is worth teaching them. Standardization is really important. Even if training is being delivered by lots of different universities, then we need to have standardized levels. And there's this whole concept of trainees can be supported through supervision. And I think I was really surprised that this was one of the biggest differences. And I think one of the things we felt also was that we had to find ways that hierarchy didn't limit how trainers were trying to develop. So in the second phase, it was a phase where we were rolling this out to more people. So we attached the courses either to existing events, such as to the exams that were happening. So we trained all the examiners in TTT before the exams. We went to their annual congress. And so it meant that more people then had access to this. And what we were concentrating on here was developing the skills. So, different ways of teaching, making it interactive, how to teach practical skills, embedding feedback and appraisal processes, and also conversation techniques for managing trainees in difficulty. So in phase 3, having upskilled a lot of trainers, we then set up a more formal structure for this delivery. So in each of the 10 countries, we appointed a lead. This is Chiku, who's the lead for the whole COEXTA program. So we had a lead in each country, plus a faculty member, plus a facilitator in each of the 10 countries. So we had a structure through which we could start cascading training the trainers. And then they could, in the same way as in the UK, once they were trained up, they could then start to deliver this on a national or institutional basis. And then phase 4 was really about doing this sustainably. Although we all love going out to Africa and helping them, it is really important that they are able to continue delivering this themselves. So at this advanced course, which is the one that I showed you earlier, we taught them how to actually deliver the TTT program. Then by 2020, COVID has hit. So they remotely joined our advanced TTT program that we were running for all our UK advanced group, and we had the African advanced group joining. So we really had the benefit of the two different cultures working together. And then after the 2019 course, it was so interesting to see how they went into their units, into their countries, and they actually implemented the TTT process. So you can see here in Mozambique, they ran introductory TTT sessions for staff from 2 different hospitals. In Zambia, they implemented the appraisal process and all the conversation skills that are needed for that. And in Kenya, here's a session where they're teaching their trainers about appraisal prior to implementing it there. And in Tanzania, they had a train the trainer session in their National Ophthalmology Society meeting. So this was so encouraging to me, because it's one thing people turning up and coming to the lectures, doing the practicals in a classroom setting. But what's really important is this is then implemented in the regions across the 10 countries in Africa. And as a result of COVID, we were always planning to do something for the day 6/6/2020. So now it's the 6th of June 2020 as a big celebration at the end of the Vision 2020 program. But actually COVID almost came to our rescue, because it was very much easier to do this online than it was to try and do it in person. So we ran a whole day with all these stakeholders, and we basically showcased all the links that there are between these different countries, and how different units have worked together to promote partnerships in eye care. Also, during COVID, we've very much developed our telelearning program. And so now we can we share materials before sessions. We can run events in a distributed fashion. So while we're delivering materials within London, we can have groups elsewhere, and maybe as far afield as Africa, with facilitators who've been trained to help them with the practical skills, but we can actually share our knowledge. These sessions can then be recorded, they can be uploaded onto the telelearning system so that they can then be used for future learning. And as a Royal College, we have a new telelearning system, our learning management system called RC Opt Enlighten. This means that we can provide materials for learning in all different modalities. We can provide them anytime, any place, anywhere. A very efficient and flexible way of delivering education. So it means that learners can then build their own learning pathways, or they can follow ready set programs such as the Training the Trainers program. We have groups of educators who can have high levels of functionality, and this delivers a modern digital solution promoting lifelong learning and professional development. So the outcomes of the Training the Trainers program and our links with Africa have been massive. In phase 1, we were treating more than 1 million patients, more than 1 million patients per year were touched in some way by the Training the Trainers program. In phase 2, we published our results in Globalization Health. In phase 3, we established the national team members and also started a TTT program in Indonesia using the same model. By phase 4, we trained over 100 participants. We had 23 faculty members, and within the structure of COEXA, a TTT subcommittee had been created. As I mentioned before, this has also had huge benefits to us on basically a personal level and also for the TTT program within the UK. So looking forward to the future, our advanced courses are now combined with the COEXA supervisor courses. Hopefully we can deliver more remote joint modules with the UK. And then the COEXA countries are now looking to cascade TTT to adjacent countries, and particular in West Africa. And just in the way that we've involved our eye care professionals, the COEXA countries are wanting to upskill their non-medical professionals as well. So really cascading the Training the Trainers program has enabled us to improve the level of training across the whole country, but also with other countries in the world. Thank you.
Thank you very much, Melanie. We now pass to John Ferris.
Thank you, Bernie. Good afternoon, everyone. It's a pleasure to be joining in this RCOP symposium. Just before I start sharing my screen, you've heard from the previous 3 speakers how COVID has impacted on exams, on training, and on recruitment to the specialty. But as Bernie alluded to in the first of his slides, really, the impact on surgical training globally has been massive. But the one small silver lining to this COVID cloud is that it has made us think outside the box on how we deliver our surgical training. And in the next 15-20 minutes, I just want to show some of the remote supervision techniques, which have been devised mainly by our trainees, incredibly innovative trainees, and how we can make the most of training opportunities, and how we can receive training from great trainers around the world who are in a different country from us. So I'm just going to start sharing my screen now. And hopefully you can see those slides. Good. So financial disclosures, I have designed and own the Simulated Ocular Surgery and Simulation Gallery websites, which feature in this presentation. So I'm just going to play this video. I'm going to speed through it a little bit. It was designed by Sunil Mamtora, and in it he shows how we can actually have remote supervision of trainees undergoing simulation training when they don't have a wet lab, but they have a theatre space which is vacant, and some kit to help them with that remote supervision. So here we go. So Sunil here is describing how to use a system called MicroRec. MicroRec is a company which make these 3D printed adapters for any operating microscope or slit lamp for that matter. And it fits with any mobile device, be it an iPhone or an Android device. So the MicroRec is attached to the teaching arm of the microscope or to the teaching arm of the slit lamp. An adapter for your phone. And of course, the phones these days, especially iPhones, with these amazing high definition cameras, the picture you're getting of the supervised technique or indeed live surgery is much better than almost any camera attached to an operating microscope. So this can be streamed live to your supervisor via Zoom, who's in a different part of the hospital or outside the hospital altogether. You can use it to record live surgery and then get feedback later on from your consultant during the end of the operating list. So it's a very simple way of doing this. You can also then stream your videos directly to the screen in theatres, so the theatre team can see in high definition the surgery. So the MicroRec system is a great bit of kit for not only theatre remote supervision, but also in casualty sessions. So for example, I'm just pausing the video here, with the slit lamps in Cheltenham, and George Sala in London is doing this with their MicroRecs. You can have a relatively junior trainee seeing patients and being remotely supervised by a more senior clinician elsewhere. So they're getting exactly the same view in their slit lamp as the trainee is getting, and we're doing a pilot project on that. So if you don't have a MicroRec,
USB to any laptop, and then use that in any video calling app such as Zoom or Microsoft Teams. As we can see, the quality is excellent, and we can see Sunil doing a beautiful 3-step incision.
so it's a DVI system out from your microscope, linked up to the your laptop with a video capture card. And that provides, again, really good quality imaging, which can be streamed live. The other setup we've used is not only this, but also a camera on the trainee's hands. So you're getting 2 feeds of the supervisor, as you'll see in a moment, with Will Dean supervising Sunil. And he's getting a picture of his hands here, and also the capsular axis.
Okay, yeah, you can see that really nicely here. Good, and then keep taking it out into orbit. And then once you've about there found your, yeah, that's perfect. And then start just re-gripping and leading it exactly where you want it to go on that plane, on that circumference. That's very good. Always worth re-gripping before you come to the 12 o'clock position.
Yes, so this is very accurate.
Yeah, yeah.
So you can see the view that Will is getting is fantastic. He can see exactly what Sunil is seeing. And in fact, in this next little video clip, when Sunil was doing a more mature cataract, Sunil was struggling to see the edge of the rexis.
Is it?
So he can't see it, but Will can actually see where the edge of the rexis is.
I don't think it's all the way out there. It's probably closer to the center there.
Or is this just a big bundle of viscoelastic?
I think that's more the viscoelastic. I think it's just gone out towards the 3 o'clock position and down ever so slightly. So around about there, down a little bit. There, that's it, that's it, that's it.
So you can see Will was able to successfully direct Sunil to the edge of the capsular rexis flap. So you get this amazingly high resolution, real-time feedback. And it's something that can be set up in any theatre and then linked to Zoom. But the extra camera on the hands is great, because there were a few occasions when Sunil didn't have his wrists in the right position, and Will was able to give him guidance. If you just have the view down the microscope, you miss some of those little cues. So the next thing we're going to talk about are the digital dry labs using these compact Zeiss STEMI microscopes, which are linked with our internal Wi-Fi network to an iPad. So you can view trainees operating on this iPad system. And here's a screenshot of my LabScope app, which is the free app downloaded onto your iPad or iPhone. And you can see there are 8 trainees operating at one time. You can click on one of these videos. You can record what they're doing. And in pre-COVID times, we ran dry labs like this. and use them to record trainee surgery. And the nice thing about this system is you don't have to be right beside the trainee. You can be in the corner of the room watching them, so they don't feel that pressure of their consultant sort of breathing down their neck. And the next little video is just how these work in practice. So they've got, some of them have got a camera on top, and that camera can be attached then with an HDMI cable to a large screen. I'm just going to pause the video. So we've got two corneal surgeons here. Paul Tomlins is undertaking the demonstration here. Alex Short is then pointing to what's going on in this big plasma screen, and the trainees are watching that. And once they've watched the video, they then copy what's being done. So complex corneal laceration here that Alex is suturing. And once he's undertaking the suturing, they practice that. This was another workshop going on the same day, which was a trabeculectomy workshop. And Nitin Anand here and myself are watching a trainee doing a releasable suture on a trabeculectomy flap. We can record that, play it back to the trainee, who can then refine their technique. So the college have adopted this. This is the fantastic facility that we have in London. This is the dry lab section of the skills faculty center. And these are the STEMI microscopes all set up for a course. And these are screenshots taken of a corneal graft and a scleral fixed IOL taken down the STEMI microscopes. So with COVID, of course, running face-to-face courses has become difficult. So how can we actually use this great setup for providing remote training? Well, the trainees can take these microscopes home, can link them to Zoom, and the next video is a video of a workshop we ran with Uday Devgan, the cataract coach in LA. And this is Uday's take on our remote capsulorhexis training with 4 trainees at home in the UK and Uday in Beverly Hills.
CataractCoach.com, remote capsulorhexis training. It's the world's first remote digital dry lab. I recently had the opportunity, through the courtesy of Professor John Ferris, to participate in the world's first remote learning digital dry lab. So I was here in Los Angeles, and there were doctors in training in the UK who are using a surgical microscope in their own home and using the internet connection to broadcast to me their creation of a capsulorhexis in a model eye. And I could guide them remotely, and we had a fantastic time. We had a handful of young doctors, all did great and really improved their skills. And I think this is something very important. This is the way you can do things in the future. You can have a coach like me helping you and coaching you from many thousands of miles away. And I want to show you the video. Check this out, and we'll talk more at the end.
Remotely supervised capsulorhexis simulation session with Uday Devgan, the cataract coach. Using Zoom video conferencing, we ran this simulation session with 4 trainee surgeons at home in various locations in the UK. Uday was able to join us from LA to give us live feedback and tips on our capsulorhexis techniques using model eyes from Philips Studio. We used a STEMI 305 microscope with an AxiCam as the camera feed for the Zoom call, so the supervising surgeon can simultaneously see the microscope feed and discuss methods for improving practice. Being able to pin different video feeds means the trainer can watch multiple surgeries at once, or just one individual feed. Now watch for some clips of our supervision session.
And now look at your tip of your force and trace the circle, way better. That looks perfect now. And then you do the same thing now, re-grab. And now obviously your base is towards the right and your tips are to the left. Perfect. Yeah, fantastic. And now here at the end, keep tracing it. Don't pull centrally. Keep tracing it like you're doing it. The rhexis even has to go around one more time. Then you'll finish it and you won't be able to see it. Widow's peak there. Now it's perfect. So if you have a spot that's irregular, just encompass it or encircle it with the new rhexis that you want to do. Now I usually do a counterclockwise rhexis, but there's some cases where I go clockwise. It really doesn't make a difference.
So as you can see, it was just a fantastic hour-and-a-half session with one of the world's best trainers. He thought it was great. And in the word of Will Dean, who'll be known to many of you, Will said this is really democratizing eye surgery training. So no matter where you are in the world, you can have access to fantastic high quality training. So at the college, we recently ran the cataract complications course, and we had 12 trainees in the dry lab, which you saw pictures of a few minutes ago. And Rebecca and Sunil, two of our trainees, were at home. And they were being supervised remotely by Larry Benjamin. So they were able to join in the course virtually, and it's a form of hybrid course.
The recent cataract surgery complications course was the first of the college courses to be run both virtually and in person. The virtual participants were able to watch the talks and engage with the speakers in the comfort of their own home via Zoom. Screen sharing meant they were able to watch the lectures and videos in real time along with the in-person participants. With a STEMI microscope and AxiCam connected to Zoom, the virtual participants could also join in with the practical side of the course, performing Mayugan ring, capsular hooks, and capsular tension ring insertion and removal using a model eye. There was even a remote supervisor, Mr. Larry Benjamin, who was also at home, who watched and gave advice and guidance to the virtual participants. He could watch both participants simultaneously, and each trainee could also watch the other's progress. Here are some clips taken from the remotely supervised Zoom call.
So if your deficiency was at say 3 o'clock on the left-hand side there, then it would go in as you're doing it, because then it sort of pushes against the deficiency as you put it in. Alternatively, you can just flip it upside down and do it the other way if the deficiency is to the right. Again, so if you try and engage that, you might find it's too big to go through. Okay. I know you're in. Good, well done. Well done. And gently guide it round with the injector. Is it under the capsule? That's good. Be careful at this point, that's it. And that often happens, that top scroll going over the edge of the injector. So you probably can get it out like that, but if you want to be obsessive, then yeah, you just manipulate that into the cartridge with the hook. That's it. It should probably come out of the wound at that size anyway, but
I'm just going to forward on to putting in some MST capsule retractors for a localized nodular dialysis.
If you can leave it as it is for the moment and do one, then the bag is under tension and it won't move while you take them out. So it's probably, you could do them one at a time.
So I'm just pausing it. You can see really great resolution video, and it meant that Rebecca and Sunil could join in with all the practical aspects of the morning part of the course. And we think that these hybrid courses is what we're planning to do for next year at the college when we're running a trabeculectomy course, an ocular trauma course, a cataract complications course. There's no reason why we can't have people from remote locations joining in if they've got this sort of setup and a remote supervisor. So instead of just having 15 people taking part in the course, we can have multiples of that taking part in the course, watching the lectures, going into breakout rooms, being supervised, and having exactly the same surgical experience. In fact, I think Rebecca and Sunil maybe got a better deal. They had 2-to-1 supervision, and the trainees had sort of 4-to-1 supervision at the college. So this is something maybe we as a college be looking to join with yourselves in India and elsewhere to set up these remote courses, or remote courses being staged in India with UK supervised trainees joining in virtually. So it's not just for intraocular surgery. The World Society of Pediatric Ophthalmology, led by Ramesh Kakanoya, who many of you will know, and David Granite, we've run these virtual strabismus workshops where we had trainees from around the world joining in with remotely supervised supervision from 5 expert trainers. This is the desk I'm sitting in front of at the minute. I've got a ring light, an iPhone linked app, a Camo app that gives a really high quality webcam footage, a strabismus model eye, and the next clip is the WISPOS basic strabismus workshop that we ran. Hetty was in Joburg, Derek was in Sheffield, and they'd never done any strabismus surgery before until this very afternoon. Again, now that's too vertical, Derek. Okay, so that if you do that in real life, you're going to go through the sclera. So if you watch my needle again, if I just try and just trying to make this full screen, because I'll just try and show you the difference in angulation. So he was pointing his needle directly down into the sclera, making his first scleral pass. We're just trying to demonstrate how not to do that. And I'll hold a different model eye here at an angle. So you're approaching it like this, and you're relying on you just going at the right depth. Just push down vertically. So on the sclera, just push down, go in a straight line, and roll your finger and thumb, and you'll get the right depth. So at no point am I going like this. It's flat, pushing it down, and then rolling it. This is Derek 40 minutes later. So here is Derek, who had done no previous strabismus surgery, making 2 safe scleral passes at the end of our session. And bearing in mind his first. So these models were made by the trainees themselves: ping pong ball, silicon foam, and a matchstick. And everybody, no matter where they joined us from around the world, and there was 4 different continents, were able to make these simple model eyes. And if I just forward you on to Derek at the end of the case, this is him doing a medial rectus recession, double loop. And this is a guy who'd done no strabismus surgery. He had been on the Royal College's basic microsurgical skills course a few years ago. But his needle handling, his suturing skills in the space of an hour had developed enormously. And I personally would be happy to let him undertake parts of a strabismus surgery case with me in theatre on the basis of this. And we ran the advanced course literally last Saturday, where we were doing adjustable sutures, plications, transpositions, inferior oblique surgery. And all of these are available if you go onto the Whispers YouTube channel. You'll be able to see those in more detail. So we can do it for strabismus surgery. It's not just, and oculoplastic surgery, not just for intraocular surgery. All of the things that you've seen, all the videos you've seen, plus videos of how to actually connect your microscope or the camera to a computer, onto Zoom call, most of which are done by Sunil and Rebecca, are on the Royal College of Ophthalmologists section of the simulation gallery. So gallery.simulatodocularsurgery.com, and in the Royal College section, if you click on that, you come to all these fantastic videos on surgical skills practice, training modules, training facilities, and it's free for everybody to access. So there's also the Instagram link, which will take you to those videos as well. So I'd just like to end by thanking Rebecca and Sunil for all their amazing work and their innovation, for Uday Devgan and to Wispos for their backing of these simulation programs. And I'm just going to stop sharing now. Thank you very much.
Great. Thank you very much to my 3 colleagues, Fiona, Melanie, and John, for their really great presentations. I think in a sense, we're very lucky that we live in a world where technology is able to support these innovations. And in a sense, COVID, if you want to take a positive out of it, has kind of accelerated how quickly we have had to adapt, not just the way we do consultations, from face-to-face to video or telephone, but also how we are able to offer continued training to our trainees, even from across the globe, as John has so nicely demonstrated. Now, we did have one question in the Q&A about the dual sponsorship. So I wonder whether I can pass to Fiona.
So I had popped an answer in for the candidate, Bernie, but absolutely. So answers should be available. If you look on the college website on the dual sponsorship page, and you'll find the education and training team will also help you. But we can have a three-way connection for dual sponsorship. So we can have that the consultant who's supporting you in India does know somebody in the UK who knows the person you'd be going to work with, or the other way around. We can have a three-way connection. So the team will help you with that, I'm sure. And if you have a look on the website, we'll send you some links for this later as well. But there are links to a number of other documents around teaching and training and resources for trainees as well. During COVID, because of course it was quite a busy time for us. Unfortunately, dual sponsorship was held up for a while, but will be starting again, I know, though perhaps in smaller numbers. And our trainees have had to have big changes to their curriculum as well, which has gone through the GMC. So there's further information if anybody's interested in any of that or getting in touch with us through the college. I'm happy to answer any questions.
Thank you very much. One of the things that the group of us thought about was that if your society has any interest in the TTT program being run out there or any other further information, your General Secretary, Professor Sharma, has our contact email address, and so can contact us to ask for any resource. But we will try to put together a little pack to send to Professor Sharma to share with AIOS members with some of the resources from today's talks as well. In terms of the dual sponsorship, certainly COVID has restricted it, but it is beginning to open up now. And that one of the things our what we call the BMA, which is an association for doctors, is they're also trying to see whether the fee, because you do at the moment, you have to isolate whether the fee is actually paid for, not by the person who's coming from overseas, but by the government or the trust. So
the other thing that might be worth...
I don't see... Yeah, please.
Bernie, one of the things that might be worth mentioning also is for colleagues in the AIOS to just keep a little watch on the college's skills section of the website, or we can post details of the 2022 courses, because there will be, as I mentioned in the talk, a virtual link to that. So if there are institutions in India, teaching hospitals, LV Prasad, Arvind, or we might want to join in and have remote attendees at these courses, it would be great to pilot those with the All India Society. So maybe that's something we can get into a dialogue with over the summer and autumn to set up these sort of collaborative courses, surgical courses.
Thank you very much.
Sorry, I was going to say, I think something else that our colleagues in India may well be really interested in is our learning management system, which is going to be AIOC Enlighten. We'll be launching the full version in a couple of months' time. But there we will have learning materials specific for ophthalmology. But what we do as a Royal College is to try and provide materials that aren't provided elsewhere. So particularly in the fields of generic skills, personal and professional development, and the kind of development of training and all these topics we've been talking about today, we will have a lot of materials to support that on AIOC Enlighten, so you can join that. There will obviously be clinical sections to it as well, so you can get all the clinical material. But I know that you can tend to get that elsewhere, but certainly the personal and professional development, there'll be a lot of material there, and it will be open to non-members to look at as well.
Thank you very much. One of the things Fiona Spencer talked about was about running exams, our college exams internationally. So we would be grateful if AIOS could cascade that information to the members to take the opportunity to take the college exams, especially since it is going to be run in India fairly soon.
Maybe worth pointing out that actually on the learning management system, there will be quite a lot of materials that will be actually directly mapped onto the curriculum. So obviously our exams are assessing our curriculum, but all the learning resources will also be linked to the curriculum as well. So if you do want to sit our exams to then go on to RC Opt Enlighten and be able to help all those learning resources address your needs for the exam, would also make a very good package.
So I think there was just one Q&A about contact details, and I don't see anything else. So that being the case, then again, I want to thank my colleagues for their presentations and helping to run this session. And again, a very big thank you to AIOS for giving the college a chance to present our work and material.
Thank you so much, all the speakers. And thank you for this wonderful session that we had. And with this, I conclude the session. Thank you so much, everyone.
Thank you.
Keep well.